Hello, everybody. Welcome to Health from Home by Aditya Birla Health Insurance. My name is Dr. Vijay Agarwal, and I'm a medical oncologist at Aster Hospitals in Bangalore. We are here today to talk about breast cancer awareness. October being a breast cancer awareness month, I think it is very important that we are all aware about the risks that breast cancer poses to us as a society, as a family, and to us, each and every individual and our loved ones. I'll take you through over the next half an hour to 45 minutes over what I think everybody should know about breast cancer and be aware of breast cancer. For the Breast Cancer Awareness Month, we'll talk a little bit about introduction of breast cancer, what it is and what it means to us, some of the causes and risk factors of breast cancer, some of the symptoms of breast cancer that women may present with, and how we diagnose breast cancer, what treatment options are available to our patients, and how we should undergo screening programs to identify breast cancers earlier on, and a little bit about cost and funding for treatment. We talk about breast cancer. Breast cancer is basically any tumor or malignant tumor that arises in any part of the breast. So in any of the cells of the breast, if there is a cancer that comes out of it, we call that breast cancer. It is found predominantly in women, but please let us not forget that men can also get breast cancer because men also have breast tissue. When we look at the breast is the organ that sits on top of the chest. It is comprised of predominantly fat, okay, but it also contains lobules, and multiple lobules make up a lobe. This is where the milk is produced. And once the milk is produced through certain ducts called milk ducts, it goes to the nipple area from which the milk is discharged. So essentially, the three main components of breast are your fat tissue, the lobules, and the duct. And the reason I'm bringing this up is that when we talk about types of breast cancer, okay, there are different types called lobular breast cancer, which essentially means the cancers have arisen from the lobes of the breast. A ductal breast cancer, which essentially means that the cancer has arisen from the ducts, and we occasionally call them sarcomas when the cancer arises from the fat tissue. Apart from that, you also have blood supplies and lymphatic drainage from the breast. And if cancers arise from them, they are also called as sarcomas. So there are different types of breast cancer that you can get. Occasionally, the whole breast can be engulfed with cancer, where we don't always know where the cancer is coming from, but we know that it involves all the breast components, and we call that inflammatory breast cancers. Breast cancer is a big problem worldwide as well as in India. This is the Globocon data of 2018, which looked at the different types of cancers, and breast cancer is the commonest cancer across the world when you compare to all types of breast cancer. Pretty much is in the same league as lung cancer. So 11.6% of all cancers that we see in our practice in the worldwide is either breast cancer, okay, or another 11.6% is lung cancer. However, the death rate from breast cancer is slightly lower compared to lung cancer, okay, because of improvement in early diagnosis as well as treatment. I will talk about that a little bit later on. But needless to say, worldwide, breast cancer is one of the commonest cancers that are seen. When we come to India, okay, it is the commonest cancer. 14% of all the cancer that we see in our practice is breast cancer. It is more common than oral cancers and lung cancers, which are predominantly smoking related. So breast cancer is more common than either of smoking related cancers, which are oral cavity cancers and lung cancers. And 14% of all cancers are because of breast cancer in India. When we look at the age distribution of breast cancer, worldwide, the common age, particularly in the Caucasian or the Western population, is about 50 to 60 years. In India, we see that a decade earlier on. So this is from various Indian registries looking at age predisposition to breast cancer. And in Indian population, we see them between 40 to 50. So they present a decade earlier in Indian people. And in our practice, certainly in my practice, we're seeing more and more women in their mid or late 30s presenting with breast cancer. And this changing trend is really worrisome. Let's talk about causes and risk factors of breast cancer. And I'm going to spend some time on this because I think it is very, very important that we understand what risk factors are there that predispose an individual to developing breast cancers. Some of these risk factors we cannot change. However, some of them we can modify to further reduce our risk of developing breast cancer. So I call them unmodifiable risk factors and modifiable risk factors. Let's take a look at unmodifiable risk factors. Sex and age. Being a woman means you have more breast tissue compared to males. The fact that you have more breast tissues, there are more fat, more lobules, more ducts, the more likelihood of developing breast cancer as opposed to the male counterpart. In fact, male breast cancer is quite rare, and 1% of all breast cancers are male breast cancers. However, we shouldn't forget that they can also get breast cancer. So if any men have enlarged breasts, or nodules in the breast, they should also seek professional advice. Age is another unmodifiable risk factors. The older an individual is, the more likelihood of developing breast cancer, or more chances of developing breast cancers. And we saw in our earlier presentation slides that in Indian women, they present a decade earlier on. But however, as the age progresses, the risk of developing breast cancer gets higher and higher. And about 1 in 12 women in India are at the risk of developing breast cancer. Menstrual duration. Now, menstrual duration is very, very important, unmodifiable risk factor, because you cannot control when you achieve menarche or when you achieve menopause. Now, the sooner a child starts having periods, the increased likelihood of developing breast cancer. So historically, women had always been at the age of 12, 13 developing or starting their periods, but nowadays we're seeing them much earlier on, pretty much at the age of 8 to 9 years old. So the sooner it is, the more likelihood of developing breast cancer. And when we're looking at menopause, historically women were getting menopause at around 45 years of age, but now it's pushing up to 50 years of age. Okay, so the duration of menarche to menopause is much longer nowadays compared to historical figures, and that increases the risk of breast cancer, and that is predominantly because of hormonal interplay. We know that estrogen is an important risk factor for developing breast cancer, and all women have estrogen. It is what defines them to be a woman. Now, if you have an early menarche and a late menopause, the duration of exposure to estrogen is much, much higher as opposed to late menarche and early menopause. So because the duration of exposure is much longer in those people, or in those women, there's an increased likelihood of developing breast cancer. Again, not having children or having them later in life is also a very important, and I've put this as unmodifiable risk factors because it is not always within our control of how quickly we can have children, or we can have children at all or not, because there are other issues with regards to fertility, our lifestyle, our jobs, our family pressures, and so forth. Having said that, every time a woman gets pregnant and then breastfeeds, the duration of exposure to hormones is much less, okay, as opposed to for those women who do not have children or have them later in their life and do not breastfeed. And this is quite important to understand because historically, our parents, our grandparents had about, on an average, 7, 8 children, maybe 10 children, and a lot of the time, fertility period was spent in terms of pregnancies and deliveries and breastfeeding. But nowadays, I think 1 or 2 children and 3 to 6 months of breastfeeding is what we tend to do because of our lifestyle, certainly in the urban areas. And that is increasing the duration of hormonal exposure to the women and thereby increasing the risk of developing breast cancer. And it is something that we need to understand. And the reason I've put it here as unmodifiable is that there's not something that we can always change. Now, family history is very, very important. Again, an unmodifiable risk factor. Now, if there is a history of breast cancer in the family, so if the mother or the sister or mother-sister had developed breast cancer, there is an increased likelihood of an individual developing breast cancer. The commonest cause of gene defects causing breast cancer are defects in 2 particular genes called as breast cancer 1 gene and breast cancer 2 gene, commonly called as BRCA1 and BRCA2. Now, if any women have any of these gene defects, there is increased likelihood of developing breast cancer in excess of 50%. So I think it is very, very important that if there are family history of breast cancers, particularly clusters of 2 or more individuals in the same family developing breast cancer, I think it is very, very important that an individual seeks professional advice with either a local doctor or with a genetic counselor to identify his or her risk of developing breast cancer, and then look at options of how to reduce that risk, because options do exist of reducing the risk of developing breast cancer despite there being a strong family history and a gene defect being present. However, it is important that we understand that just because there's a gene defect present does not necessarily mean that an individual will definitely get breast cancer. And I think it is equally important to get that message out that just because you have a gene defect does not mean you will definitely develop breast cancer. It is a lot more complicated than that. And the reason why that's complicated is that you get two genes, one gene from your mother and one from your father. And if one of them is defective, the defect needs to arise in the other gene as well for an individual to develop breast cancer, which may not happen. If it does happen, that's unfortunate and the individual may develop breast cancer. But if it does not happen, then that individual may not develop breast cancer. And it is something that we have to keep in mind before making any important decisions with regards to reducing the risk of developing breast cancer if a gene defect is present. Radiation exposure, again, we can't do much about it. It could either be occupational radiation exposure, particularly if you're working with radiation machines, such as doctors in the hospital are exposed to X-rays and CT scans and radiotherapy machines. Again, certain occupation will involve some amount of exposure to radiation. But more importantly, if some people have had childhood cancers, particularly lymphomas, they may have had radiation to reduce or to treat the lymphoma, and that would increase the risk of developing breast cancer, particularly if the radiation has been given around the chest area. There are various other small risk factors that can increase an individual's chances of developing breast cancer. Their diabetes. So if someone has diabetes, then there's a slightly higher chance that they might develop breast cancer. Again, if an individual has more dense breast. So what I mean by dense breast is that it is basically your component of the tissue versus fat. If there's more ducts and more lobules and less fat, which is there in younger women, particularly who have not achieved menopause, they have more lobules and ducts and less fat. And as they get older or post-menopause, the fat component increases and the ducts and the lobules come down. But if an individual has dense breast, then there is an increased likelihood of developing cancer because they have more lobules and ducts present. There is some evidence that a tall woman may have a slightly higher risk of developing breast cancer after menopause. But the evidence is not very, very strong. Nevertheless, some evidence do exist, and those people should probably be aware of it. When we look at modifiable risk factors, this is something that we can do, we can change in our life to ensure that we reduce the risk of developing breast cancer for us as well as our loved ones. The most important ones are obesity and sedentary lifestyle. Obesity is a very, very important risk factor for developing breast cancer, particularly if your BMI is high, that is more than 25, and certainly if it's more than 30, I think drastic steps would need to be taken to reduce an individual's risk of developing breast cancer. Even if an individual is not obese, but they lead a sedentary lifestyle, particularly if they're physically inactive, okay, there is an increased risk of developing breast cancer. So I think getting regular exercises about 3 to 4 times a day, or 3 to 4 times a week is very, very important for all of us. So maintaining a healthy body weight and doing physical activity will reduce our risk of developing breast cancer, and not doing them can be counterproductive and increase our risk of developing breast cancer. And it is a big problem in our society, particularly in the urban areas where our job involves a lot of office work, where we don't get much exercise, and obviously we tend to put on weight as a result of our diet that we take. And again, it is very important that we modify those diets and increase our physical activity to reduce our risk. Alcohol consumption is another big problem, which is an important risk factor for developing breast cancer. It is related both not just to the duration, but also to the quantity of alcohol that is consumed. So if you drink more frequently and for longer duration, there's a higher risk of developing breast cancer, as opposed to reducing the quantity of alcohol and drinking it for short periods in terms of durations. I think the maximum allowable for women is about one small drink a day. I think they should probably stick to that. Taking oral contraceptive pills, which can have some hormones in them, will increase an individual's risk of developing breast cancer, and hence they should only take oral contraceptive pills under prescription from a doctor and be aware of the risk that is involved in developing breast cancer if consumed. Some people are prescribed hormone replacement therapy, particularly if they are undergoing menopause and they have severe menopausal symptoms. And again, in those situations, because the hormone replacement therapy do contain hormones, they are at an increased risk of developing breast cancer. Again, it should be done only under a medical guidance with a prescription and not on their own. I've also put not having children or having them later in life as a modifiable risk factors, because if it is possible, one should try to modify it. Or I accept that it may not always be possible to have that under an individual's control. Now, breastfeeding is a different topic altogether. It's very, very important. And I would urge all young mothers to try to breastfeed for as long as possible, because that would reduce an individual's risk of developing breast cancer. And counterproductive would be not breastfeeding would certainly increase the risk of breast cancer. When we talk about diet, there is no direct link between the type of diet one consumes versus development of breast cancer. But as a surrogate marker, the increased fatty diet would certainly help in increasing the weight and thereby increase the risk of developing breast cancer. And having a healthy diet, particularly high in proteins and fibers, would certainly help. Again, there's no direct link between smoking and breast cancer per se, but we know that smoking causes a lot of different types of cancers and may also have an impact in developing breast cancer. And we should cut down on smoking or stop smoking altogether. And the sooner we do that, the better it is for our loved ones as well as our society. And particularly smoking and alcohol tend to go hand in hand in a significant number of cases. And hence, stopping both alcohol and smoking will certainly alter an individual's risk of developing breast cancer. I've also listed certain factors that are not associated with breast cancer, because there are a lot of myths surrounding these factors, particularly the use of antiperspirant. There are certain myths that using antiperspirant will increase an individual's risk of developing breast cancer and should not be used. And there is no truth, or certainly there's no evidence to the fact that using antiperspirants will increase an individual's risk of developing breast cancer. Another myth that is circulated around occasionally is the use of bras. Any kind of bras can be used, and they do not have any specific link with breast cancer. So using bras of any kind does not increase the individual's risk of developing breast cancer. Abortions, again, have no link to breast cancer. Okay, so medically induced abortion will not increase an individual's chance of developing breast cancer. Again, there's a myth that having a breast implant will increase an individual's risk of developing breast cancer, and that is not true. Women can safely have breast implants without worrying about the risk of breast cancer. Let's talk a little bit about the symptoms and diagnosis of breast cancer. When we talk about symptoms, there are various symptoms that a woman can present with, which may be a sign of breast cancer. Certainly, any change in the nipple, such as the nipple turning inwards, or any discharge from the nipple, or the significant discoloration of the nipple, can be a sign of breast cancer. And I think if there are any changes in the nipple, women should present to their local doctor to get that examined. If there is a lump either in the breast or under the arms, it is very, very important that that gets evaluated or checked out, because that could be a sign of breast cancer. So that is any lump under the arms or in the breast. Even if someone has swelling of all of the breast tissue, not just a lump in the breast, but the whole breast is swollen, again, that could be a sign of breast cancer, and that needs to be checked out. Any change in the skin, such as skin dimpling, any rashes on the skin or on the nipple, or any irritation on the skin, can also be a sign of breast cancer and needs to be evaluated. So in a sense, if there's any change in the skin, the lump, the size or the presence of a lump, or any discharge or any alteration in the nipple, I think a woman should get her breasts checked out. It is very important to know that not always a woman will have pain if they're developing breast cancer. So pain is not necessarily an important symptom to look out for. The vast majority of our patients do not have any pain in the breast or the lump and could still be having breast cancer. So how do we diagnose breast cancer? So when someone presents with a symptom that we think may be cancerous or that women may be having breast cancer, there are 4 questions that I need to ask of myself to identify how we proceed with regards to diagnosing and treatment of breast cancer. The first and the foremost question is, I suspect that the patient may have breast cancer, but does the patient really have cancer? Can I confirm that the patient does have cancer? The second question that goes through my mind is that if the patient has cancer, what type of breast cancer is it? We spoke a little bit earlier about the different types of breast cancer, and different types of breast cancers can be treated differently. And hence, it is very important for me to find out what type of breast cancer it is. And not just what type of breast cancer it is. I think today's in the era of personalized therapy, we have gone further in terms of looking at picking out any one type of breast cancer. For example, if it's a ductal breast cancer, we start looking at molecular characteristics of those tumors, such as the estrogen receptor hormones, the progesterone receptor hormones, and the HER2, which is called as the growth factor receptors. So we start looking at identifying these receptors to see what type of receptors are expressed through molecular diagnostics to further tailor make our treatment or prognosticate as to how aggressive the tumor may be. So once we've confirmed that the patient has cancer, we need to identify what type of cancer it is. And once we've identified what type of cancer it is, the next stage is to identify how aggressive is the cancer. Is the cancer very aggressive or is it not so aggressive? Because the urgency to treat will depend upon that. And apart from that, where has it spread to? Is it just in the breast, or has it gone to the local lymph nodes in that area which drain the breast tissue? Or has it gone to the other organs in the body, such as the bones, the lungs, the liver, and the brain? So these are the 4 questions that I need answering before I can start advising any treatment. So there are various investigations that we do to get answers for these questions that go through our mind. Clearly, if the woman has symptoms, a breast examination is mandatory. And a breast examination, in fact, both the breasts should be examined in complete detail and not just one. A breast that is symptomatic, because occasionally women can have cancers in both the breasts. Mammograms are basically x-rays of the breast, which are taken in the hospital, which gives us good images of what the breast density is. And occasionally, or in fact not occasionally, the vast majority of the patients, if there is any breast lump, that can be identified in the mammogram when it is done. We also occasionally tend to do breast ultrasound, particularly if the breast is very dense, because dense breasts are not very well seen on mammograms, and a breast ultrasound is usually done to identify if there are any lumps or any tumors present in the breast. We may also need to do further investigations such as the MRI of the breast or a PET CT scan or a CT scan. Basically, a PET CT scan or CT scan is evaluating the whole body to see if there is any cancer, has it spread to any other organs in the body. Now, these are the images that we need to do. Apart from the images, we also need to do a biopsy. A biopsy is the one that is going to give me the answer to the first 3 questions that I have in my mind, which is, does the patient have cancer? What type of cancer it is, and how aggressive is the cancer? It is only the biopsy that tells us the answers to these questions. Now, there are a lot of myths associated with biopsy that, and we hear that in our day-to-day practice, that if you touch the tumor, it starts to spread, it starts to grow, and that we shouldn't touch the tumor and so forth. And most of them are myths. There is no truth to that at all. Without a biopsy, it becomes very, very difficult or near impossible to decide on treatment, particularly in the era of personalized medicine. So basically, a biopsy is a sample of a tumor that has been removed. Usually, an ultrasound probe is put on the tumor area, and a fine needle is inserted into what we think could be cancer. Okay, and a small piece of the tissue is removed. It is not painful because a local anesthesia on the skin is given. It's a reasonably quick procedure. It takes about half an hour or so to do, and it is an outpatient-based procedure, and patient does not need to be admitted in the hospital. And once we take this tissue, we send it to the laboratory for a detailed evaluation that tells us whether it is cancer, what type of cancer it is, how aggressive is the cancer. So we get all of these answers through doing a biopsy. And once we've confirmed it is cancer, we also send it for molecular diagnostics to identify further if any receptors are expressed or not, because a lot of our treatment depends upon what receptors are expressed, or if there are no receptors expressed either. All of this tests or investigations help us to stage the breast cancer. And it is very, very important that before we treat any breast cancer, we need to know the stage of breast cancer. There are essentially 5 stages: stage 0, 1, 2, 3, and 4. Stage 0 are basically very, very small tumors that are not invasive, and they have not gone into the tissue area. They're just within the glands where it has arisen. And we usually call them precancerous lesions. They're not true cancer by definition, but they're precancerous lesions. Stage 1 are tumors that are less than 2 centimeters and is within the breast area and has not spread anywhere else. Stage 2 are basically slightly larger tumors, which measures anything between 2 to 5 centimeters, and again limited in the breast itself. Can occasionally involve a couple of nodes, but hasn't gone anywhere else. Stage 3 are tumors that are much larger in size, which is 5 centimeters or larger, or have gone to the nearby lymph nodes. And stage 4 are those that have gone outside the breast tissue and to other organs in the body, such as the bones, liver, lungs, or the brain. And the treatment depends upon the stage of the tumor. With up to stage 3, the intent of treatment is to try to cure the patient. With stage 4, it becomes very, very difficult to cure our patients, and the emphasis is more on quality of life and longevity. But when we use the term early breast cancer, we mean breast cancers of stage 0 to 3, where we are trying to cure the women. Unfortunately, the vast majority of our patients do present earlier on, which is stage 0 to 3. And what we want now is to move from stage 3, where the vast majority of our patients now present, to stage 0 to 1, which is where the vast majority of the Western population women present. So we need to increase or reduce the stage at which our patients present. I will talk a little bit about how we can do that. So our treatment of breast cancer essentially involves, again, certain questions that we need to answer, and overall preferences of our patients. So again, the treatment would depend upon what type of cancer it is. If it's an inflammatory breast cancer, the treatment is slightly different versus lobular versus ductal. Again, if it's a sarcoma, the treatment is different. And a lot of the treatment also depends upon the molecular characteristics of the tumor, such as are those receptors expressed? If there are, which ones are expressed? Or are there no receptors expressed? Again, the aggressiveness of the tumor also guides us significantly as to how quickly we should start treatment, how aggressive we should be in terms of treating the patient, and what options are available. Again, where has the cancer spread to greatly influences our decision of how to treat, whether it has gone to the nearby lymph nodes or not, or whether it has gone to any other parts of the body or not. And I think that does change our treatment significantly. Also, the patient's overall health. Younger, fitter patients, we can try to give more aggressive treatment. However, in elderly patients who are 80 plus and are frail or may have a lot of comorbidities such as diabetes, hypertension, heart problems, or stroke, then our treatment options do become limited. And clearly, patient preference nowadays has a huge, huge role to play in how we treat our patients. There are a lot of patients who say, I don't want to lose my breast completely. I just want you to remove the lump. There are some people who say, no, remove my breast completely. I do not want to take any chance at all. Some people want treatment that does not induce hair loss. Some people are okay with hair loss. Some people have certain prejudice towards one type of treatment versus the other. And so all of these preferences are taken into consideration when deciding treatment for an individual. So treatment of breast cancer by and large involves various options such as surgery, chemotherapy, radiotherapy, hormone therapy, targeted therapy, and immunotherapy. Most early breast cancers, by and large, surgery is the mainstay of treatment. When I'm talking about early breast cancer, I'm talking about stage 1, 2, 3, and obviously stage 0 as well. Now, all of these patients need surgery as a curative modality of treatment, and a significant number of patients are cured by surgery alone. Clearly, if they have a slightly aggressive form of cancer, or the cancer has spread to the nearby lymph nodes, or it's larger in size, then other modalities of treatment such as chemotherapy has an important role to play in terms of achieving a cure or increasing the likelihood of developing a cure. And that is occasionally suggested either before the surgery or after the surgery. Radiotherapy also has an important role to play, particularly if the woman is trying to conserve her breast and do not want to lose the whole breast. If they have something called lumpectomy, which is just removing the lump or the tumor and trying to conserve the breast, they all need radiation as mandatory to reduce the risk of the cancer coming back. Even if the cancer has spread to the nearby lymph nodes and the woman loses the whole breast, they also still need radiation to further reduce the risk of recurrence. Other treatment options such as hormone therapy, targeted therapy, or immunotherapy depend upon the molecular characteristics of the tumor, whether the receptors are expressed or not, and if an individual receptor is expressed, such as if hormone receptors are expressed, they undergo hormone therapy. If growth factor receptors are expressed, they undergo targeted therapy. And if immunotherapy markers are expressed, they undergo immunotherapy. So these are personalized treatment options depending upon the type of the tumor that the woman has. Over the past 30 years, we've gotten much better in terms of managing patients with breast cancer. In fact, over the past 30 years, there's been a 29% reduction in the number of patients dying of breast cancer. So why do we think that is? Why are we getting better in terms of treatment? So we know that the incidence is increasing and has been done over the past 30, 40 years. However, the death is coming down. A lot of that could be because of better treatment options that we have available today, but also because of early diagnosis. And I think early diagnosis is what is crucial and has the most impact in reducing mortality over the past few decades. And the early diagnosis is predominantly because of screening programs that exist worldwide, India included. And I think we need to emphasize on the role of screening for all our loved ones and how we can identify diagnosing cancers earlier on rather than later on through the process of screening programs. So what is breast cancer screening? Breast cancer screening is basically undergoing mammograms of both the breast for any woman who is more than 40 years of age. In the Western population, the age limit varies between 45 to 50, depending on country to country. But certainly in India, because we're seeing breast cancers earlier on, I generally recommend that women undergo mammograms from the age of 40 onwards. 2 yearly for the average risk women, but yearly for women who are at a higher risk. And we've already discussed the risk factors for the women. So if the women fall into any of these high risk components or have a strong family history, they should probably undergo yearly mammogram. Clinical breast examination is basically an examination of the breast by a doctor, which your local general practitioner can do, and should be done once a year if a woman is concerned, and particularly if facilities for mammogram may not exist nearby. So at the very least, clinical breast examination is required. All women should be aware of the breast, how the breast feels, looks. They should be self-aware of the breast and should undergo self-breast examination on a regular basis. I think that is probably what is going to have the biggest impact in early diagnosis. And there are lots of tools and articles available on the net to learn how to effectively do self-breast examination. I'm not going to talk about that in a much more detail, but essentially, women should examine the breast in front, looking at the mirror with their hands down, hands up, lying down position in all the three positions. And both the breast as well as the underarms and the neck should be examined, which will result in a complete self-breast examination. The reason for doing this screening program is to identify cancers earlier on. And we've already seen the stages of breast cancer, and the numbers that I've put up there basically denotes the 5-year survival from stage to stage. So if someone presents at a stage 0 to 1, the chances of survival is 98 to 100%. So that is as good as it gets. Okay. If it's at stage 2, so slightly larger tumor, so more than 2 centimeters, less than 5 centimeters, the survival is still very good, in excess of 90%. And if it's stage 3, which is 5 centimeters or larger, or there are lymph nodes involved, it is 70%. But if it does become stage 4, the chances of survival, or certainly 5-year survival, is less than 25%. So in our practice, we certainly see women predominantly in stage 3 and 4 stages. And what we want to do is we need to move them to stage 1 and 2, certainly stage 1 if possible. So try to identify small tumors that are less than 2 centimeters, which gives our patient population the best chance of survival. And that can predominantly be done through extensive screening programs. So I can urge everyone that please undergo regular screening programs, either self-breast examination, clinical breast examination, or regular mammogram to identify breast cancers earlier, because that is what is going to have the maximum impact on an individual person's survival from breast cancer. Clearly, treatment of breast cancer is getting more and more expensive. As and as we are getting better, there are more drugs coming out. There are various surgical modalities and high-end radiation options coming out. We spoke a little bit about targeted therapy and immunotherapy. They can also be very, very expensive. So clearly, there is a significant cost to treatment which needs to be funded one way or the other. When we talk about early breast cancer, certainly in the private sector, the cost of treating an early breast cancer, depending upon the type of breast cancer and the modalities required to treat, can range from anything between 3 to 40 lakhs over a duration of 3 to 12 months. And it is a significant expense. So we should not undermine or not understand that there is a huge cost to treatment. And if the woman is at a stage 4 breast cancer, which is what I use the term metastatic breast cancer, then the treatment can go from anything between 10 lakhs to 1 crore, which is a lifetime cost because of the significant cost of immunotherapy, targeted therapy, and chemotherapy that comes with it. And because the breast cancer treatments are better, women are living longer, and the downside of that is clearly the cost of treatment becomes exorbitant for the patient. The various ways of looking at funding treatment, clearly there are government hospitals, which can be either free or subsidized treatment is available. There are a lot of government schemes that exist in private hospitals or corporate hospitals, such as central government schemes or for army people, for ex-servicemen as well as in-service army people. They can avail treatment in private hospitals at subsidized rates, which are funded by the government. Public sector units as well as private companies have their own funding options where they fund treatment, but by and large, more and more of these companies are going down the insurance route or health insurance route to fund their employees. The vast majority of our patients, certainly in my practice, about 70%, but I'm sure it's much higher in other practices, particularly in Tier 2 cities, where out-of-pocket expenses are huge. The vast majority of the patients do not take out any health insurance, and there is out-of-pocket expenses, which results in catastrophic health expenditure. And what I mean by catastrophic health expenditure is that it pushes an individual from an above poverty line to below poverty line just because they have to fund the treatment. So treatment which goes on in lakhs and lakhs of rupees can be very, very difficult, and not very many people have huge bank savings account which can fund these treatment. On an average, about 5 crore individuals, Indians, drop down from above poverty line to below poverty line purely because of out-of-pocket expenses for these for health expenditure. So health insurance is another modality of funding treatment, and I would urge every individual, wherever possible, to take out some form of health insurance to try to fund the cost of treatment. Clearly, this is something that cannot be predicted, cannot be anticipated, and the vast majority of our patients think of health insurance only after they've developed cancer or developed some health setback rather than proactively. So can I urge every individual to try to take out some form of health insurance to cover the cost of healthcare in the unfortunate circumstances that they do develop breast cancer. That is for me today. I'm quite happy. Thank you very much.